Good afternoon, everybody. Thank you guys for joining us. We want to welcome the Maternal Health Echo brought to you by the Center for Substance Use Training and Telemonitoring Center at Bevo, Texas, in collaboration with Perinatal Psychiatry Access Network. My name is Micaela Contreras, and I will be facilitating in our discussion today. A few quick housekeeping notes. To begin with, let's see. First, to help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, you may click on the speech bubble icon in the navigation bar on the bottom of your window. If you're joining via phone, please make sure to provide us your email, phone number, and name to csta@uthscsa.edu. We encourage everybody to join us by video for our discussion portion of the later half of the session. But no matter how you are joining us today, we are happy that you are here alongside us. We encourage you to speak, but at this time we ask you to stay mute unless you are speaking. There are a lot of us in this space, so keeping our comments brief will allow others the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or discussions. Our didactic today is going to be about navigating the intersection of sleep, perinatal health, mental health, and substance use, and will be presented by Dr. Alag. Following that, we will discuss our case presented by Dr. Elmer. We will start with introductions, followed by the didactics, announcements, case presented, and open discussion. Thank you again for joining us today. We're going to go ahead and start with our introduction of our team hub. And that will be, let me see. That is going to be Dr. Sobrin.
Hi, good morning, everybody. My name is Joy Subrin. I'm a OBGYN social worker and doctor in behavioral health at University of Arizona in Tucson. And I'm just so glad to share some time with you all today.
Thank you, Dr. Subrin. Next, we will introduce Dr. Humphrey.
Hi, my name is Emily Humphrey. I'm a doctorate of family nursing practice out of Texas, and I've worked on both the inpatient and outpatient end for substance use disorders with pregnant women.
Thank you for that. We want to welcome our hub team members and thank you for being here today, Doctor. And we want to introduce our presenter, Dr. Alag. Thank you as well, and we look forward to your presentation just whenever you are ready.
Hi, everyone. I'm all ready to go ahead. Okay. All righty. So we'll be talking about today navigating the intersection of sleep, perinatal mental health, and substance use. Next slide. Disclosures. I really have no financial disclosures. Next slide, please. All right, in terms of the learning objectives from the presentation one is identify the signs and symptoms of sleep disturbances, substance use, and perinatal mental health disorders across pregnancy and postpartum. Also describe how sleep patterns, which are disrupted, and substance use can impact perinatal mental health outcomes. And last but not the least, kind of apply the evidence-based screening tools and integrated care models for assessing and managing sleep, mental health, and substance use in perinatal patients. All right, next slide, please. Okay. So, as we all know, sleep problems are incredibly common during pregnancy and right after childbirth. And about 78% of pregnant individuals, they report some form of sleep disturbance. And these could range from insomnia to obstructive sleep apnea to restless leg syndrome, and then the rhythm disruption, right? Just to kind of name a few. Now, why in general does sleep really matter? So one is because it's uncomfortable, true, but looking at bigger causes there's always an increased risk of perinatal depression, anxiety, and suicidal ideations. It can also interfere with fetal development and maternal-infant bonding. So I think the crux of this is that the good news is really that early screening and intervention for sleep problems can serve as a preventative strategy for mood disorders. And addressing sleep may be one of the most accessible points kind of for entering and to be able to improve the maternal mental health outcomes. Next slide, please. Okay. So one is the sleep problem, but when we add the substance use aspect to it, the risk factors are significantly compounded. So what happens is when pregnant individuals, they would use substances along with, ongoing sleep issues. There are multiple things that can happen. So there could be medical concerns, there are psychiatric concerns, there's socioeconomic challenges that they go through, which kind of puts them into a high risk category. Per the NIDA, about 5% of pregnant women, they use one or more of the addictive substances, which includes opioids, alcohol, cannabis, stimulants, and tobacco, to name a few. Now, importantly, is the pregnancy is one of those windows for opportunity of intervention, right? Patients are motivated to engage in treatment. But the reality of the situation is that there are tons of barriers which can actually come in the picture and not let everyone be engaged in treatment. So the barriers are stigma, fear of legal consequences, and the fragmented care systems. Next slide, please. Right. Let's see what's the mechanism or kind of understand the mechanism that kind of links the substances to sleep issues. Like how do these illicit drugs really hamper the sleep? Next slide. Right. Now, of course, each substance will impact the sleep in one or the other way, and that's often negatively. So in terms of stimulants, if you see like the cocaine and the methamphetamine, they reduce the total sleep time and they cause fragmented sleep. When you look at cannabis, it's great. That's what most of the individuals will tell you, including pregnant females. They initially help because they help you to sleep pretty quickly so that you're able to sleep quickly. So the latency of your sleep is shortened. But the unfortunate part is over time, your quality of the sleep is actually reduced or worsened. The opioids, they suppress the restorative deep sleep, and also at the same time, they can exacerbate sleep apnea. For alcohol, very similar to cannabis, it can actually help you to sleep pretty quickly. So like the latency of sleep onset is pretty short, but it gives you fragmented sleep. That's one, and it's very hard to actually go into deep sleep as well. And nicotine, interestingly, which a lot of individuals do utilize, is also kind of does somewhat similar, but it delays the onset of sleep. That's one. It reduces the rapid eye movement cycle of one of the sleep stages. And then it also kind of does not let individuals go into deep sleep stage. Now, these disruptions in sleep are not only impacting the sleep quality, but it also kind of has a cascading effect, right? Which is on your mood, the stress response, and the cognitive functioning. Next slide, please. The next is the withdrawal-induced insomnia, right? So on top of these substances themselves, withdrawal can also significantly cause insomnia. So sometimes that can last for like days to weeks. It could be during, it could be postpartum. So common withdrawal symptoms that you might notice with nicotine, opioids, or benzodiazepines include insomnia. It could be nightmares, and then the restless sleep. Now, for postpartum individuals, the disrupted sleep can interfere with recovery, right? Because that kind of creates a lot of stress within the body. So it can actually make people return to use. It can cause a lot of problems in maternal-infant bonding. And like I mentioned, there's risk of return to use. So it's really important to address the withdrawals, or else it'll be hard for the individual or the mother to be sober and to be able to assist the infant or take care of the infant, and the maternal fetal bonding, of course, is impacted. Next slide, please. So the indirect effects are, of course, with all these substances, there's a poor prenatal care, there's housing instability, there's intimate partner violence, there are neonatal complications. So they all kind of contribute to unsafe or unpredictable sleep environments. Nighttime caregiving stress, of course, kind of interferes with the sleep as well, and especially for infants with a neonatal abstinence syndrome, it can further impact the mother's sleep. Next slide, please. So how does one identify? So when you're evaluating perinatal patients, especially those with substance use, we need to keep a very close eye and kind of understand the key related signs and symptoms. So some of those that have been mentioned here are the trouble falling asleep, right? Frequent awakenings, excessive daytime fatigue, or kind of sleeping too much during the day, nightmares or the vivid dreams, which could be associated with withdrawals, commonly noticed with stimulants, but it can also be noticed with nicotine and so forth. Sleep distorted breathing linked to opioids or tobacco, restless sleep or movement disorders, and then there could be agitation, anxiety, or irritability close to bedtime. And these may be some of the early red flag signs which are pointing towards either withdrawals or unmanaged mental health issues or very high risk of return to use. Next slide, please. All right, now let's talk about the consequences on the mother. So one is that the red highlighted portion that kind of mentions is that 35.6% of perinatal substance use disorder pregnancies actually have adverse outcomes, versus if you compare them to 25.1% for those who do not actually use substances. So it's a pretty significant number. I mean, the difference is pretty significant. What they notice is for mothers, what it really means is it worsens their perinatal depression and anxiety. There's higher rates of suicidal thoughts and risk for self-harm. It's difficulty staying engaged in any kind of treatment. There are more frequent relapse rates postpartum, and there's decreased confidence in the mothers being able to take care of the baby. So the confidence is really less in being able to parent, and also their functioning. Next slide, please. In terms of the fetal outcomes, of course, substance use during pregnancy and the sleep disruption, it can, of course, be associated with one is the preterm birth and the low birth weight, poor neonatal behavior, so that could be irritability, sleep-wake dysregulation, the neonatal abstinence syndrome, which is noticed in individuals who are exposed to opioids in utero, disrupted bonding and feeding routines. And then lastly, the sleep regulation is also a pretty significant problem. So the early life kind of issues that are seen can affect everything ranging from the fetal development to actually emotional dysregulation later in life. And these are all linked to the substance use and also, of course, the sleep that is impacted. Next slide, please. All right. So there are just certain, literature review, which I was looking at and kind of mentioned that for pregnancies that are exposed to fentanyl, 58% of them actually delivered preterm, versus 48% of them during this pre-pandemic time that delivered preterm babies. And the mean birth weight was actually about 2.3 kilograms. For tobacco, almost 5% was the difference in terms of the birth weight, so nearly doubles the low birth weight risk. And cannabis, which individuals do report helps a whole lot, it was noted to have, they were smaller for gestational age, low birth weight, and then there were congenital anomalies as well that were noticed. Next slide, please. All right, well, I guess the thing that I mentioned before is the important part of the scene is that we can actually make some changes at an early stage by screening them and then kind of like integrating with whichever field or branch, it is required based on how they're doing, right? And that's very helpful with these screening tools. Next please. All right. So I guess this is just one of the flow sheets to see, which I would expand on as we move forward, but and specifically on the screening tools. But that's one of the three of the screening tools. The two I want to briefly talk about here is the PHQ-9, which is universally known for depression. It's not specific perinatal, but it can still be very much used. G87, which is for generalized anxiety, can absolutely be used as well. The other three I would be talking as we move forward. I guess once you screen them based on what their scores are, you kind of want to reach out to either the behavioral, the psychiatry team, or the addiction team or the counseling team. And if, of course, if they're remotely present, then you connect them with telehealth resources. Collaborative care model is extremely helpful. So kind of working with their OB, psychiatry, addiction, social work, like counselors, everyone together to kind of make sure the individualized treatment plan for the patient. In terms of insomnia, of course, first line being the sleep hygiene, CBTI, to focus on the trauma, which is one of the significant reasons why individuals actually go ahead and use substances. So trauma-informed substance use treatment as well is really important. And then medications that are safe in pregnancy must be considered if required or if indicated. Consistent follow-ups are very important just to make sure how they're doing and how things are going, whether they're low risk or moderate risk or high risk. And then I guess, could we move on to the next slide, please? Okay, great. So one of the screening tools is the PROMIS Sleep Disturbance Form. This was actually developed by NIH and is a validated form. If you look at the strength, it says it is psychometrically strong, which basically means it's pretty reliable, but it's pretty accurate. So it is scientifically, it is used a whole lot. It is used in different settings. It's used in research settings and clinical settings. And it is actually pretty easily integrated into the electronic health records. And also it is used alongside the PROMIS anxiety scale, the PROMIS depression scale, and things like that. It does help us in assessing sleep quality and disturbance. Again, this is not specific for perinatal, but it can still be utilized for perinatal population. Next slide, please. All right. Now, the next two screening tools that I mentioned here is one is the Edinburgh Postnatal Depression Scale. Even though the name says postnatal, it is utilized for both during pregnancy and after pregnancy. It is widely accepted and validated. It is actually a 10-item form, which you would probably see in the next slide, the form, but it's a 10-item one, and it assesses the mood in the past 7 days. And also kind of talks about the suicidal ideation. Now, if an individual does test positive for suicidal ideation, irrespective of what's the score, they're very high risk and they need to be immediately connected to the services with resources. Each of the item is scored from 0 to 3, and total score is 30. The cutoff is if it's more than or equal to 10, then someone is possibly going to have depression. So kind of close follow-up is very essential for these individuals. But if someone is over a score of 13 or a cutoff score of 13, it likely indicates major depression. So it's important that they're connected to the resources as soon as possible, right? Whether it's the psychiatry team, the addiction team, and the collaborative care model is extremely useful in such situations with their OB and the social work and the counseling and everything together. This is actually one of the gold standard for screening perinatal depression. The next one is the ASSIST, which is alcohol, smoking, and substance involvement screening. It is a WHO validated tool as well. And what this really form does is it has 3 categories. So one is low, moderate, and high. Within these 3, if an individual qualifies for low risk, then just a brief counseling is great. If they qualify for moderate, they're recommended to go for behavioral counseling or therapy. And if they're high risk, then it's almost required for them, to kind of seek some help in terms of mental health or addiction or combined. This can be either clinician administered or self-reported. Again, this is not specific, but it is very much utilized in perinatal population. Next slide, please. This is the Edinburgh Postnatal Depression Scale. Next slide. And the next one has this screening tool that I utilize as well. Okay, next slide, please. All right, the SBIRT framework is really the screening. So one is the cyst we talked about, audit is for alcohol use, and DAST is actually for the drugs, right? It excludes the alcohol and the nicotine assessment. So that's kind of like you screen them. Based on the screening results is a brief intervention based on one of the most common techniques that we utilize for substance use, that is motivational interviewing. That is not the only one, but one of the most commonly utilized to meet the patient where they're at. And then last but not the least is the referral treatment, right? If you feel like when you screen the patient, if they're high risk, of course, you must actually recommend the patient treatment sources eventually. I don't want to really go over the motivational interviewing, but I just kind of wanted to mention here on the slide that what are the communication tools and what are the fundamental principles of motivational interviewing. I think the crux is that it is very important to meet the individuals where they are and not just force or be judgmental towards what they want for themselves and for the baby. Next slide, please. All right, I guess this is just really a quick glance looking at the different screen tools, and for the sake of time, I will just move on to the next slide. All right, so of course, before we go straight on to the pharmacological management, we talk about the counseling approach is extremely important. So sleep, we kind of touched on briefly before. The CBTI is really helpful. Sleep hygiene education in terms of like using bed only for sleep and sex, not eating, not watching TV, not using phone in the bed as calm as possible, having kind of like not too warm environment to sleep. So some of the sleep hygiene education is really important. Relaxation techniques are extremely helpful. So it really depends on an individual which technique would help, but sleep hygiene education usually is extremely helpful. And then the journaling of the sleep patterns is helpful to kind of go over the CBTI. Substance use is the motivational interviewing, the 5 A's, which is really kind of understanding with the individual, that asking them if they need the help, kind of advising them if it's for nicotine cessation. Of course, you want to assess them, evaluate if they are looking for that help. If they are, you assist them and you arrange the resources for them eventually. And then also with brief intervention based on the screening of SBIRT. Mental health, specifically trauma-informed care, CBT, social groups, support groups are very beneficial. Next slide, please. All right. So pharmacological considerations, considering in the perinatal period where they could be either pregnant or the mom could be lactating after the baby is born. One is the antihistamine, right? So doxylamine, diphenhydramine, hydroxyzine. None of them are actually contraindicated in breastfeeding. And they can also be used during pregnancy. But what I read was interesting that ACOG, that possibly there can be some maternal respiratory depression during pregnancy. So all they recommend, and I think we all are pretty mindful of that, is that be cautious when you're going up on the dosage of these antihistamine medications, because they kind of like block the H1 and they cause sedation, which is a side effect, and it actually does help treat insomnia. The next one is antidepressant. So the antidepressant, which is actually approved, FDA approved in general population, is doxepin, right? Which is actually not utilized in perinatal period because of very little research. Trazodone, on the other hand, which is extremely common to be utilized in general population. One is it is not FDA approved for insomnia. And the second is it is not utilized for perinatal period. The reason being, one, animal studies have actually indicated congenital anomalies and fetal reabsorption of the metabolites, so it's not safe. And also, it was the trazodone and the metabolites were actually found in the lactating rats, the milk of the lactating rats. So not recommended to utilize either of these during the perinatal period. Antipsychotics, these are one of my favorite ones. Olanzapine and quetiapine are extremely safe. They're safe in pregnancy. They are excreted in breast milk, so there's really insufficient data when someone's breastfeeding them, but during pregnancy, they're really safe. And again, you need to be very careful when you are going up on the dosage for these medications as well. Next slide, please. Anticonvulsants, gabapentin is kind of utilized at lower dosages, but there's really no consistent data which is available regarding gabapentin during pregnancy. It is also excreted in breast milk, but we don't really have any necessary literature for adverse effects in infants that are breastfed. Tegabine, on the other side, actually does have a lot of teratogenic anomalies that have been reported. So we refrain from using it. But gabapentin is pretty safe compared to other anticonvulsants for insomnia. This was interesting for me, benzodiazepines and Z drugs. And the reason I said in residency, what I learned or how we used to practice is absolutely it's a no. Again, I'm not saying we should be utilizing it as much now, but it can still be utilized for severe cases of insomnia is one. It can be utilized for intermittent use or like short-term use, right? And that's kind of consistent with how we want to use it. Now, in the second and third trimester, interestingly, benzodiazepines are considered to be actually a source of concern. But in the first trimester and in the late pregnancy, the data is actually pretty reassuring, which basically says that there's no risk of congenital birth defects. And recent studies have not actually supported major malformations when you're comparing the exposed versus the unexposed, right? And I'm thinking they've not done a whole lot of studies in second and third trimesters because it has to be a short-term indication. So probably by the time they get to second trimester, individuals are probably not on benzos, but this is only my 2 cents. But there were more studies on first trimester where it's considered to be safe and later part of the pregnancy. Not all benzos are safe because the aspect we have to consider is one, it must not have an active metabolite. Like diazepam has an active metabolite, so must not be utilized during pregnancy. And the other is that it must have either a short or a medium elimination half-life. So oxazepam or lorazepam, drugs like that are actually safer in pregnancy as long as they're used carefully and they're utilized intermittently or short-term. Z drugs are actually safer compared to benzos. Specifically, the ones they mentioned were zopiclone and zalpalone, where there's no evidence found in increasing the malformations when they were exposed in first trimester of pregnancy. Again, second and third, I did not see much literature, and these are specifically for pregnancy. We'll talk about lactation in just a minute. Anyone who's on benzos and Z drugs, they can, give birth in a hospital setting where there is NICU, so that just in case when the baby is born, if they do have any adverse effects, those effects can be addressed right away. Next slide, please. During lactation, again, short-acting benzos like lorazepam is preferred over longer-acting ones, and again, no active metabolite is definitely preferred. And Z drugs are alternative drugs to benzos, right? In breastfeeding women with primary insomnia. And again, there's limited data, so we just need to be careful when utilizing these medications, and specifically Z drugs. I guess the last one I want to talk about is orexin receptor antagonist. Orexin is the only one that is FDA approved in general population for sleep maintenance. There's really no literature or studies there which kind of support it in pregnant or lactating mothers. And whatever studies it did do in animal models, what they found out was that actually it was the sulforexin was excreted and the metabolites were excreted in higher amounts in the rat milk. So it's not necessarily used in perinatal period as well. Melatonin is considered to be, which I've not mentioned here, is considered to be safer. But if you look at Romiltion, which is a longer acting agonist, is not recommended again because it does have active metabolites. So it's not recommended to be utilized during pregnancy. Next slide, please. All right, I just wanted to highlight the insomnia, but also want to make sure that we all understand that treating the co-occurring substance use disorders should be offered and initiated the patient expresses readiness of wanting to bring about a change in their mental health as well, and not just necessarily treating the symptoms, but really treating the mental health diagnosis should be the goal. Next slide, please. Just I want to briefly touch on the ethics and responsibilities. So confidentiality is really important. Non-judgmental communication is extremely important. Body language is so important for individuals because anyone can pick on that. And if we are being judgmental towards our patient population, they're very quick to pick that up and actually not open up and not seek the help that they should be seeking. We're supposed to actually support our patient population. Pregnancy is one of the biggest opportunities, like I mentioned before, for pregnant females during pregnancy or right after to be able to seek help. So I think this is the best time to be able to support them. Equitable access, so kind of individualized treatment plans are very important. So kind of catering to what the individual need is important to be taken into consideration when someone's kind of deciding their treatment plan. And then we must absolutely address the stigma and bias in perinatal addiction care. A lot of physicians or a lot of healthcare professionals do actually judge and create biases when pregnant females are using substances versus the ones who are not. So it should all be treated equally and should all be given the same care. Next slide, please. All right, I guess we're towards the end. So stigma can absolutely lead to delayed care. There's a fear of judgment. There's underreporting of substance use. And of course, if there's a bias, it will show up as assumptions about parenting trustworthiness, which can re-traumatize the patients who've already gone through so much of trauma in their life. So always utilizing a first person language is important, being extremely supportive, advocating, being non-punitive, helps not only to reduce the harm, but also kind of build a trust with this population and in general, just with any patient population that we work with who have addiction or substance use issues. So the resource toolkit that I'm sure when the slides would be sent out, you could have access to these. And I think that should be it. I think we have the references in the next 2 slides if we could move forward. All right.
Yes, we want to thank you, Dr. Alag, for such a great presentation. We now want to open it up if there's any questions from the learning community. I did see that there was a question into the chat by Rita Wiltz. Does alcohol have any percentages on pregnancy outcome?
Can you repeat the question again?
Yes, it says, does alcohol have any percentages on pregnancy outcome?
I'm pretty sure it does. So, alcohol used during pregnancy has a significant, kind of dose-dependent impact, right? So there's really no safe amount or kind of like safe drinking, but I'm not sure if there's a specific percentage for that. But I think from what I vaguely remember is up to 30% is the risk for, it's 25 to 30% of risk for fetal alcohol if there is heavy alcohol use. Yes. And then if it's moderate or if it's mild, then, the risk is separate and different. But definitely fetal alcohol is almost 30% of full fetal alcohol with heavy alcohol use. Does that help?
Thank you. And if anybody else has any more questions, definitely type them into the chat or unmute your mic to ask them. And you see there is a question by Claire Ruley, postpartum period. How do we address sleep regarding caring for a newborn? Seems like there's no way around it.
Is this specifically for mothers who are going through this time or just in general? Could you help me clarify the question, please?
She did state in general.
Well, I guess that's a hard one. And I say that because I feel like we struggled a lot ourselves. But I think in general, it's really important to have great support around. Resources are really helpful as well. In general, even if there's no substance use involved, I think it's really important to have great support, which is, I think, the number one thing and the most important. Kind of giving the mom the time for herself, letting her take some rest, allowing, kind of encouraging her to take care and self-care, continue to do self-care as time goes by, I think is really important. I guess that's probably what I can think of in terms of how one can take care of infants. I think it's really sad how sometimes individuals are pressurized to breastfeed the babies. I mean, it's important to give breast milk, which is great, but if some individuals are not able to like breastfeed, I think it's still okay to like encourage them to breast pump if that's something they can do, and still be able to feed the young one. But I've had patients come into our clinic and let us know like how their family pressurized them to kind of go for only breastfeeding. So, which can be very tasking for a lot of females. And I would support like whatever kind of helps them with their peace of mind should be supported and advocated for. So that would be my another 2 cents to that, but not sure if that helps at all.
I think I'll add to that too. I think it's something that we all can do as healthcare providers is just to ask moms about their sleep and to take it seriously. I also had three very rough sleepers, and I know, especially with our last one, I would bring it up to my pediatrician and it was kind of blown off like, well, that's a baby, but it was significantly impacting a lot of different things. And I think often sleep is brushed off as this is just a normal part of it, where sometimes it's just helpful to talk to someone and troubleshoot with somebody some ideas to help get a little bit more sleep, or to talk about breastfeeding and alternatives and things like that. And so for any of us that are interacting with these women, to take this concern seriously and try to help them find ways.
And I do see Dr. Horse with her hand up.
Yeah, so I'm a reproductive psychiatrist. With Baylor, and I'm part of the PeriPan team. At our clinic, we recommend if there is some help for the mom to try to get 4 to 5 hours of consolidated sleep by skipping one feeding and going to bed, say 8, 9, 10, whenever after that feeding, skip the next feeding, and then be up on call or get up for the next feeding whenever that is. That tends to work for a good number of people if they have someone in the home with them. For single mothers, it is so difficult, and there we're encouraging them to think about who in their world can help them, basically. So that they can get some consolidated sleep. But I think in the literature, it's like ideally 5 hours like continuous sleep is a lifesaver, can really make the difference for mental health.
I couldn't agree more. I feel like we're just all on the same page. Thanks for letting me jump in. I didn't know if this was for the whole hub, so um, it is. I couldn't agree more that the conversation about normalizing that it doesn't have to be all breast, that you can introduce other forms of feeding, that you can introduce other people. I'm thinking about Willow Wish and some of the grant-funded doula programs out there. Just allowing somebody to say, this feeding pattern is keeping me up all night. And I am starting to have foggier thoughts, and I'm feeling like I can't sort through my problems, right? Because that's what happens to our brain health. So anyway, I just really appreciate all of you saying, give some opportunities for shifts. So that's a little behavioral health piece. I'll be quiet. I see someone's hand was up a second ago.
Yes, we just for the sake of time, we are going to go ahead and move on to the case presentation, but I do understand that Hannah Rabin did have her hand up, so if you're able to type the question into the chat, we will definitely have one of our hubs answer the question. So we are going to move on to the case presentation. Please walk us through the case. We want to welcome Dr. Elmer. Thank you.
Hi, thank y'all for having me today. I'm Sarah. I'm one of the PGY3 residents at UT Southwestern. And this was a patient case that I had, so I'll just walk y'all through it. So we had a 35-year-old white female. that the consult question kind of for us was how to best support management of anxiety and depressive symptoms in this patient who was 17 weeks pregnant, undergoing active detox from opioids and benzodiazepines. And so in terms of, psychiatric review of symptoms that were present during the psychiatric interview, definitely significant depressive symptoms, significant anxiety symptoms. One of those being insomnia certainly was a pretty significant factor in this patient's presentation. Other symptoms like mania, not present, and thankfully the patient didn't endorse any suicidal ideation. There is no history of trauma in this patient. And then in terms of substance use, primarily the two substances were benzodiazepines and opioids. So for this patient in particular, they have a 10-year history of on-off opioid use. So, kind of these intermittent periods of sobriety, alternating with active substance use. At one point, they were using heroin, but more recently, they were using fentanyl. In terms of, at the time that I saw the patient, they were using opioids and benzodiazepines for about a period of 3 weeks. Fentanyl, they were using up to 3 to 5 milligrams per day, so pretty heavy fentanyl use. And then with the benzodiazepines, they had most recently been using anywhere from 4 to 8 milligrams a day of alprazolam, again, also for the same 3-week period. And their benzodiazepine use disorder is complicated by a history of withdrawal seizures, which was actually present with the admission at the time that I saw the patient. So pretty significant substance use history, a lot of kind of complicating factors. And in terms of this patient's diagnoses, certainly, a severe opioid and benzodiazepine use disorder, as well as a self-reported history of major depressive disorder and generalized anxiety. This patient had gotten different, various forms of behavioral health treatment kind of throughout their life. They had been, established in the past with outpatient psychiatry, outpatient substance use, had been on, a number of different psychiatric medications. At the time that I saw them, they were on methadone. They were on a diazepam taper for the benzodiazepine use. They were on escitalopram for mood and anxiety, quetiapine for sleep, and hydroxyzine as needed, scheduled and as needed for breakthrough anxiety. And then in terms of inpatient services that they had received, they hadn't had any prior inpatient psychiatric admissions, but had a couple of different residential treatment stays for substance use disorder. No use of mutual aid programs or support groups. And just as a note, when I saw this patient with the psychiatry team, there was a separate team kind of managing the addictions side of it. We had some colleagues from addiction medicine who were managing the methadone and the Valium. But for us in particular, we were more so targeting like the mood and the anxiety and the sleep symptoms that were pretty bothersome and disruptive to the patient. In terms of the PDMP, we certainly checked the PDMP, and the patient had been on buprenorphine and a combination of buprenorphine and naloxone in the past. And then just to kind of get to what their current medication regimen looked like, they were on methadone, kind of actively being titrated by the addiction medicine team, 75 milligrams in the morning, 70 at night, with these 5 milligram as needed rescue doses throughout the day for the opioid use disorder. They were also on a diazepam taper, 5 milligrams BID at the time that I saw them, and then a couple different medications to help with mood, sleep, anxiety. So escitalopram 10 daily, quetiapine 100 at night, and then hydroxyzine 50 3 times daily, with the option to take 25 milligrams. I think every 6 hours is needed for breakthrough anxiety. And then in terms of relevant history, they did report a back surgery at an unknown date. which, certainly could be contributing to some of this history of opioid use for the last 10 years, with uncontrolled pain and things like that. And then medically, in terms of their medical comorbidities, they do have a history of seizures independent of the withdrawal seizures. So kind of this complicated history here, as well as migraine headaches and high blood pressure.
Thank you, Dr. Elmer, for that. We are now going to be opening up the floor for any questions and insights from our learners that may provide valuable insights for this case.
Hey, Sarah, quick question. Do you know much of her current social situation? Does she have other children? Where is she living? What are her support systems in place?
Yeah, so that's a really great question. So social support system, not a great situation. Did not have much in terms of social support. Had maybe some kind of distant friends that she could kind of call on every so often, but otherwise pretty limited social support, which I think made a lot of this much harder. The patient does have other children. Not currently, that are living with her. So this, the baby that she's pregnant with would be the only child living with her. But certainly the lack of social support was a pretty tough thing in this case.
I know that was one thing that we, as the hub members, talked about when we were looking through the case. And this is going to be kind of more of a surface level answer than probably you're wanting. But also, I like to ask patients, like when they are having those anxious moments, because it sounds like her anxiety is a big issue right now. Like, what are the preceding thoughts? Like, what is contributing to the majority of her anxiety and those thinking processes? Because some of it is planning for baby and what is she going to do after, and if she doesn't have those supports. And so I don't know if she would be willing to do inpatient treatment. And I know there are also different places around Texas that allow mothers to stay there for a couple of years after their babies are born and provide those types of supports. Sometimes it's not going to solve all of her problems, right? But it can quell some of that anxiety when they have a plan in place and know that they're going to have some social support and things like that. It can help facilitate the medications that are already on board. So that'd be one thing I would dive into, is some of that social planning.
Yeah, no, I think that's great, and I'm really glad that you brought that up. I think, from our impression and kind of our assessment, certainly a lot of the anxiety, was driven by kind of this lack of social support, trying to figure out like what are next steps for mom and baby, after baby comes. And I think another significant contributor to it is just like this acute withdrawal period, like that really significant physiologic anxiety that is very much present. So trying to kind of tease apart those two things, I think, was a little bit tough when seeing her. But I love that idea. I think, in whatever way that we can support these, pregnant patients about to have babies, certainly love
Yeah.
that.
I love that idea. Oh,
Yeah.
go ahead, Dr. Alag.
Hi, thank you. Well, hi, thanks for presenting that, Dr. Elmer. I had a thought, like, I wasn't very convinced with the management. You kind of just touched on that as well, that you're on quetiapine 100 milligrams, hydroxyzine 53 times a day. And then you're also on the diazepam 5, I guess twice a day, right? But then the individual was on a very high dose of alprazolam, so it does not even look like it's an equivalent of what you would think if you're looking at the conversion. So, I mean, I guess 1 milligram of alprazolam is about 10 milligrams of, don't quote me on that, but I think that's what I vaguely remember. So I don't even think they are, and that's probably why they're requiring so much of hydroxyzine and I'm still not sleeping. So my 2 cents would be, I mean, of course, we need to treat the comorbid, like Dr. Humphrey said, and we need to make sure the anxiety is treating and what is leading to anxiety, but also a lot of anxiety and like, the other objective signs of high blood pressure and tachycardia and nystagmus and fasciculations, all of those need to be looked into and made sure they are treated before we treat just the anxiety. So I think that would have been
Yeah.
helpful to know about as well.
think I'm glad that you brought that up. And I guess for helpful context, we had seen this patient 2 weeks into this detox kind of taper. And so
Right.
the initial dose of diazepam that was used was much higher than what it was at the time that I saw her. So I probably should have kind of denoted that, hey, this is 2 weeks in. And so these are what the medications look like at this time. But she, kind of had started at a much higher dose and was, maybe midway through her taper at the time that I saw her. But I agree. I think, under treating benzodiazepine use and benzodiazepine withdrawal can significantly, it's not going to improve anxiety symptoms and will most likely make them worse. So I'm very glad that you brought that up.
That was great. Thank you.
I'm just curious. That's a pretty quick taper, though, isn't it? I'm just what do you all like to do regarding a benzo taper? Because I mean, my understanding from the recent guidelines is, slow, really slow. Like, don't make a change faster than every, I forget, 2 to 3 weeks.
That sounds about right. But also, if she's inpatient, they could be more aggressive. Sorry, I missed that part. If she was outpatient, then that would be very slow, as Dr.
She's,
Horst, you mentioned.
Okay.
she's inpatient.
Okay. So you're
Okay.
just, yeah. And she's pregnant. So that might also make you want to move
And
faster.
and just 2 more cents, I guess I would probably not do diazepam because it has active metabolites. If someone's pregnant, so I'd probably consider oxazepam or lorazepam just because, it's safer. But I guess since it's long acting, they're utilizing it, probably not safe for the fetus by itself. So
I'm Joy, and I'm part of the hub, and we had a moment to discuss this, and so I'm echoing what we talked about earlier today, which is if the patient is willing to see the benefit of inpatient at this time of her life, because sometimes I have patients that say, I've already been there, I've done that before, and I'm like, we are all allowed to grow. We all have different, spaces in our life where, it's like a dance, and even a dance backwards or sideways, you've done it before, it will help you move forward. Um, so if she's willing to go, I would mention some of the things I wrote in the chat about kind of the unspoken benefits, like accessing food 24/7 or not having to find your own rides and just having an environment that supports your sobriety. I have many patients who are just quasi-homeless living with a friend, but that home is like living with black mold. Is that environment really helping you survive? And that's become like my new favorite analogy for living in domestic violence and living kind of quasi-homeless. It's that black mold idea of like you're not gonna get well there. So if she's willing to go, those are some of the things I would think about benefits for inpatient. Outpatient, we're asking her to do a lot of changes on her own. Um, and that's just really risky. So
Yeah.
do you have a Narcan kit? Do you have somewhere you would go in the middle of the night if you needed help? Come to the hospital. That's like, I'm going to light the path for you because at 17 weeks, please come in. So I also talked about this with our team. Does she want a parent? Has anyone even asked her if she wants to parent or if she's thinking about adoption, open or semi-open or something? It just comes up in my world. So
Yeah, I think these are all really great questions. And to provide a little more kind of context and clarity, that was, a similar kind of thought with us is like in terms of this, substance use and, just kind of like looking at the bigger picture and like long-term sobriety after this acute period of detox. What is that going to look like? And the patient was agreeable to going to like a residential unit for, a higher level of care after discharge from the hospital. And in terms of, parenting and kind of where she was at with that, she very much, it was a very desired pregnancy and she was very excited about having a baby. And so that was something that she, wanted to continue with. And it didn't seem like she was really at the point of considering, adoption or other alternate kind of parenting plans. But I think the one thing that, was very reassuring to us was that she was agreeable to going inpatient to a residential treatment facility.
Great. This is all great conversation, but just in the interest of time, we will move forward to the brief announcements. We want to thank you, Dr. Elmer, for the case discussion. To receive credits for today's sessions, participants must have an active account with the Texas Tech University Health Science Center Office of Accredited Interprofessional Continuing Medical Education Office. You can create an account by clicking on the link that is going to be provided into the chat, or the instructions on how to receive credit document that has been posted on the content tab on iEcho. Participants are eligible to receive up to 1 hour of credit based on the duration of your participation. Those increments are going to be listed below. For specific questions about CME credits, please email or call the Texas Tech, the TTU HSC CME office. We want you to ask us to please let us know how we are doing by completing our evaluations. You can scan the QR code, which will be on screen, or click the link that is going to be into the chat. The evaluation will be available until 11:59 p.m. on July 15th. If you already have an account set up with TTU HSC CME office, you can use the text and attendance feature with the code 39651. The text code is only available until 11:59 p.m. today. We wanted you to please remember that in order to receive CME credits, participants must have My Portal account set up with the TTU HSC CME office. Please refer to the document and the link that will be dropped. Next is, do you have a difficult case that you or your team have encountered? CSTA offers you the opportunity to present any challenge or your organization is encountering and to receive feedback from our hub of experts and learning community. There is no need to prepare a formal presentation. It will be provided a case form to fill out and assist for your case presentation. Please email us at cstat@uthscsa.edu. The Center of Substance Use Training and Telemonitoring offers technical assistance for various substance use disorders, needs, and topics via our team of experts. To request technical assistance, please complete an online request form at CSTAT, and the link will be into the chat. I'll pass the presentation over to Jen Erdege with PeriPan program, who has a few announcements.
Hi, I'm just going to provide you a brief overview of the Texas Perinatal Psychiatry Access Network, which is known as PeriPan, which is designed for clinicians who see pregnant and postpartum women. PeriPan was created to address the maternal mental health crisis, and mental health conditions are the most common complications of pregnancy and childbirth, affecting 1 in 5 perinatal women and ranking among the leading causes of pregnancy-related death. A lack of access to care and provider shortages further compound this problem. And PeriPan has 4 major components, as you can see on this slide. We provide clinical guidance to help with a single patient case or enhance mental health care in your practice as a whole. Next slide, please. PeriPan is anchored by 12 regional medical schools and health-related institutions across Texas, as you can see on this map. Signing up is easy, and you'll reach a mental health expert by phone and can consult with a reproductive psychiatrist within 30 minutes or at a callback time that you choose. Anyone in your office can call or text to start the consult or request. Just to notice, each region has their own unique texting number, which will be provided to you at sign up. And you can call the number on the screen to enroll. Next slide should be webinar. I'm not familiar with this. This is a my slide. Who's supposed to talk about? Yeah, that's me. So for PeriPan, we'd love for you to join our webinar series, which is held on the 3rd Tuesday of each month. These sessions complement the ECHO series, offering deeper insights into perinatal mental health. On the screen, you will see a list of upcoming topics and dates. Be sure to register to stay informed, connect with experts, and expand your knowledge. And we do look forward to seeing you there. And then the last slide should be our upcoming echoes. So here is a list of topics and dates for the upcoming Lunchtime Maternal Mental Health Echo series, which are held on the first Tuesday of the month. We do invite you to join us in the future sessions to continue learning about these important topics and engage in meaningful discussions that support perinatal mental health. And I will turn it back to you, Michaela. Thank you.
Yes, great. Thank you, Jen, so much for that. And in the interest of time, I would like to move on to recommendations. Dr. Alag, can you please give us a summary of recommendations?
Hey, hi, I'm right here. All right, I guess just to kind of like sum up everything, one is that comprehensive care must include, in terms of perinatal individuals, a period is that must include sleep, what else? Mental health and substance use screening. Early intervention absolutely improves outcome for both the parent and the baby, which kind of implies the fetal development and the infant and the maternal bonding. Ethical care requires reducing stigma and improving access. And last but not the least, the ongoing education collaboration extremely essential for not just the patient, but also for the system, for the providers. So, all together, which kind of helps in taking care of individuals that we want to help. I hope this was helpful, guys. Thank you for being a part of this. And this truly does matter, and I'm sure this will help individuals out there, especially our pregnant females or rather the perinatal females out there. Let me know if you have more questions.
Yes, thank you all for joining today's Maternal Health Echo, and we extend our appreciation to Dr. Log and Dr. Elmer for their parts in today's presentation as well. As a reminder, to earn CME credits, please complete the evaluation using the link that will be in the chat. If you have a case or scenario you'd like to share, please email the CSTAT team at cstat@uthscsa.edu. We look forward to seeing you at our next session, which will be on Tuesday, August 5th at 12 p.m. Central Standard Time. And we hope you have a great rest of your day.